today we have Colonel Puneet Saxena with us. So, uh, Dr. Puneet, uh, whenever we have a patient with the pulmonary embolism who presented with the hemopsis, so how will you differentiate between the various causes of hemopsis and whether this hemopsis is because of pulmonary embolism or there is any other cause? How will you approach these patients?
Yeah, I think that's very important and can be really challenging. So, because hemoptysis is a common symptom in pulmonary embolism, and therefore it becomes very important to be sure whether this hemoptysis is coming from pulmonary embolism or it is something else, because the management will totally change with that. I think the most important thing is history, because in pulmonary embolism, the hemoptysis generally occurs because of infarction of the lung, and that happens in submassive emboli when the embolus is slightly distal. So the amount of hemoptysis is generally mild. So one thing is that if the hemoptysis is generally mild, if the patient has got associated chest pain and the pulmonary embolism is not causing any hemodynamic compromise, because massive emboli will generally cause hemodynamic compromise, submassive will not. So in that case, if the patient is having mild streaky hemoptysis with chest pain and without any hemodynamic compromise, then it is more likely that it is because of pulmonary embolism. But if the patient has got a massive hemoptysis, or if the patient has got other features suggesting that there are structural diseases in the lung, which we'll get from the history, if the patient has got history of old bronchiectasis, post-tuberculous lung, recurrent lung infections, then there's a fair possibility that the cause of hemoptysis is something else. So then we need to differentiate, because the management will change. So the next thing that we need to do is a good examination of the lung to see whether there are any structural damages in the lung, like findings of a cavitary disease or bronchiectasis. And then finally, role of imaging. That becomes most important. That's the confirmatory tool. So an imaging with a CT pulmonary arteriogram as well as a bronchial arteriogram would be required. CT pulmonary arteriogram will exactly tell us where the embolus is, and the thromboembolism will be defined particularly. But CT bronchial arteriography or aortogram may also be required if there's a structural lung disease, to see whether the bleeding is happening from the bronchial arterial structure. And that is important, because massive hemoptysis would generally occur from the bronchial arterial circulation, not from the pulmonary arterial circulation. So our management tools will completely differ. So therefore, a very important role of imaging with arteriography involving pulmonary.
Next question is, once we diagnose the patient is having a pulmonary embolism and the hemopsis is because of the infarct, so how will we manage these patients? What is the choice of anticoagulation? Directly we will start the anticoagulation, or we have to wait and do something to control the hemopsis first? So how will you approach?
So again, if we are sure that the bleeding is because of pulmonary infarct and there is no other structural disease, the bronchial circulation is fine and there is no other cause of hemoptysis, then the focus remains on treating the pulmonary infarct and the pulmonary embolism. Now, in most cases, like I said, the bleeding is not massive. It is only mild to moderate, and a cautious use of anticoagulation would generally be the standard of care. No change is required. So we would give standard anticoagulation. We may go for the full dose if the patient is hemodynamically stable and the amount of bleeding is not much. But if we find that the patient is lying on the edge, the reserves are not much, and the amount of bleeding is a little more, then we may go for a lower dose of anticoagulation, and we may go a little cautiously, a little more slowly, to see whether the bleeding is increasing with our treatment or not. Generally, in mild hemoptysis, no change is required and the standard anticoagulation would work. Regarding the choice of anticoagulation, we have to go for something which can be immediately reversed. So the first choice would definitely be an unfractionated heparin, which can easily be stopped, reversed if the patient bleeding increases. Otherwise, even low molecular weight heparin is not a bad choice, provided that we are ready with our backup to reverse the anticoagulation whenever it is required. We would try to avoid neurooral anticoagulants or warfarin or anything which will require more effort in reversing the anticoagulation, because which way the patient would go, we can't be sure. So the first choice would be UFH.
Okay, and if the patient is having a massive embolism and he is hemodynamically compromised, then in such situations, what about the catheter guided thrombolysis?
Absolutely. So,
Scenario?
so if the patient is having severe hemoptysis, massive hemoptysis, so much so that we cannot give any amount of anticoagulation, or if the patient has got hemodynamic compromise because of pulmonary embolism, so sometimes what may happen is that patient may have multiple emboli. Some emboli which have gone distally causing pulmonary infarcts, and the larger emboli which are causing uh, hemodynamic compromise. So in in those cases where we cannot give anticoagulation at all, we have to go for either a catheter-guided plot evacuation, or there are devices like Penumbra now available, and or we could go for a surgical thrombectomy. So these are those cases where we cannot go for anticoagulation at all. And only once the patient is hemodynamically stable, hemoptysis is better, then slowly we can introduce the anticoagulation.
Sometimes we saw that we are not able to exactly identify whether the bleeding is because of the infarcts or it is because of the some underlying lung pathology, because in India there are a lot of patients who have old TB history, they have fibrotic scars. So in such situations where the hemopsis is there, active hemopsis is there, so what's your message for the BAE versus spigots? So what will you do in such situations?
So true. So if the patient is unstable, so the first message is that if the patient is unstable, if the amount of bleeding is quite a lot, enough to cause life threat to the patient, the first stress has to be on hemoptysis. Infarction comes later. First, we have to control the hemoptysis because that is what is going to immediately kill the patient. So the bleeding has to be stopped somehow. So again, a very important role of imaging. Now, I remember a case at hand. We saw this patient last year who had come with the pulmonary embolism with massive hemoptysis. When we did the CT angiogram, we found that the patient had a pulmonary artery aneurysm which was bleeding. So now what happens is that when pulmonary embolism occurs, the pulmonary circulation pressure rises, and that can cause some pre-existing aneurysm to rupture, and that can cause bleeding. Here, bronchial artery embolization will not help. We'll have to do embolization through the pulmonary artery route, which is slightly challenging even for the intervention radiologist, but it's totally doable. So we have to identify the site of bleeding in our imaging. That is it from the bronchial circulation or the pulmonary circulation, and if we get some tortuous blood vessels or some active blush or extravasation, that is what we have to embolize first. Usually it is possible. Sometimes it is not possible. In those cases, two things can be done. The first approach, what I would say, what we have done in about 4-5 cases successfully, is empirical embolization. So if the patient is having massive bleeding and we are not finding any pulmonary artery aneurysm, we can safely assume that the bleeding is coming from the bronchial circulation. We can do empirical embolization of the bronchial artery from the site from where it is bleeding, which can be identified with the bronchoscope, and that would usually be able to arrest the bleeding. If that is not possible, as the last backup, we can even use spigot for buying some time to plug the airway so that the other lung remains healthy, to buy some time till other therapies work. However, not much work has been done on spigot in this setting. That should be our last resort. I would first try to go for embolization of the bleeding vessel rather than embolizing a spigot in the airway. So that would be one patient I had recently seen. So this pulmonary embolism with massive hemoptysis is quite common when the embolism is because of underlying connective tissue diseases or vasculitis. So I remember a case of Behçet's disease, medium vessel vasculitis, who presented with massive bleeding along with an embolism. So in such cases, treatment of the primary disorder is generally sufficient. You might not even need anticoagulation. So starting anti-inflammatory therapy, controlling the vasculitis, that may control the bleeding, and then the anticoagulation can be started later. So that is another important message, that when the massive hemoptysis is occurring because of an underlying inflammatory pathology like a medium vessel vasculitis or a connective tissue disease, treatment of the primary disease gives us a lot of advantage in avoiding early anticoagulation, which can hamper the patient's status. That is another message I want.
And the key home message from Sir's discussion is, whenever the patient with the embolism, with the hemopsis came to us, always try to differentiate whether the pathology is in the lungs or it's from the infarcted area. So for that, you have to do the triple phase CT, which includes the plain CT scan, the CT pulmonary angio, and the CT autogram. Second step, once you identify the cause, you have to anticoagulate this patient, and in anticoagulation of choice is unfractionated heparin in such active hemopsis cases, so that we have a antidote for that anticoagulation therapy. Finally, we have to ready for with the bronchial artery embolization and the Spiegert's measures, because if the hemopsis is much more, then we have to embolize those vessels first, and then we have to start the. Okay. Thank you so much, sir.